tightness suggests that your lung may be dry and you may potentially benefit from volume resuscitating in the critical care setting. So a useful technique is to use the lung ultrasound 6-point protocol to ensure that one is systematic in your approach. 3 points on the left and 3 points on the right that mirror each other are used. So point 1 is in the midclavicular line on each side and is found between the second and third rib or the second intercostal space. Point 2 is in the mid-axillary line, and this is between the 6th and 7th intercostal space. And point 3 is found in the posterior axillary line between ribs 10, 11, and 12. So in conclusion, there are only 4 major indications for fluid administration in the critically ill patient. That is resuscitation, maintenance, replacement, and nutrition, whether it be enteral or parenteral. When giving fluids, remember to look at them as drugs by taking into account the 4 Ds: drug selection, dose, duration, and de-escalation, and the 4 phases of fluid therapy within the ROSE concept. So resuscitation, optimization, stabilization, and evacuation. This will provide answers to the 4 basic questions that surround fluid therapy. When do I start IV fluids? When do I stop IV fluids? When do I start fluid removal? And finally, when do I stop fluid removal? So in analogy to the way we deal with antibiotics in the critically ill patients, I think it's time for us to start fluid stewardship. Thank you.
Thank you so much, Pavan. Sure, that's quite loaded in terms of what our approach needs to be when it comes to fluid management in the pregnant patient, us, and putting it in a language and in a visual that we can understand and essentially try and work through as we manage these patients. I would like to invite the audience to please, you are very welcome to post questions, comments, your experience, the challenges that you may settings. And I'm sure you're not alone. I'm sure there's a lot of people who find fluid management quite controversial in some instances and quite challenging. I'd also like to invite a very good friend of mine and a wonderful colleague, Dr. Zainab Juma, who is also an intensivist from anesthesiology. She is a head clinical unit at Chris Hani Baragwanath in the Department of Anesthesia. I know that during our training together, we faced many of these cases en route from the labor ward to the ICU and back to theater. So I think very humbled to have you on the panel today from your years of experience, and I know your passion when it comes to obstetric care. So thank you so much for joining us, Zainab.
Thank you very much.
So I want to ask Pavan, while we're waiting for everybody to essentially post in their questions, in the 4th phase, I think we're going to go through the whole journey in terms of what hypertension and sepsis manifests in pregnancy. But in the 4th phase, when we speak about the evacuation, what methods do you use in your clinical practice? Diuresis, intermittent, continuous? When would you suggest or ask the clinician to consider kidney replacement therapy? What would your advice be if your directive was to extrapolate or to start removing that fluid from the Michelin Man?
So when we look at the 4th phase, the evacuation phase, like I mentioned, we could either go from that ebb phase to that flow phase. And the flow phase is what we all hope for. You know, all that fluid that you've given, your patient has now mobilized that fluid and it is now being passed out. But most of our critically ill patients remain in that no-flow state. So when they're in that no-flow state, we need to start assessing our fluid. We need to look at our fluid status of our patients. And we have multiple modalities to look at that. From a setting outside of ICU, something simple. I mean, a lot of us have access to ultrasound. So something simple like lung ultrasound, like I've gone through earlier, will actually help you decide whether your patient is overloaded or not. We've got in the interim, if your patient is overloaded, you have increased lung permeability, you're going to need to, before thinking about pulling off fluid, you need to stabilize that patient first. So a bit of positive pressure ventilation to help you push that fluid back into the intravascular space while you actually decide how you're going to take this fluid off. Usually our approaches are diuretics first if they aren't passing adequate fluid, adequate urine. Um, and this is by something simple like Lasix. We'll Once your Lasix challenges and Lasix infusions don't work, then you'll only start considering things like RRT, renal replacement therapy, in these patients. These are patients that will generally do better with CVV HDF, so your continuous dialysis over 24, 48 hours, where you're monitoring this fluid balances, as opposed to intermittent sleds, which are there just because your kidneys are generally not functioning. But that is generally our approach. What we also need to be very mindful of in this whole period when we're taking a fluid is to try and keep your patient as negative as possible. So as much as you're stopping your maintenance fluids that everyone generally tends to forget, don't forget your fluid creep. You can give up to a liter in fluid creep just by the amount of fluid you use to mix your antibiotics in the day, about the amount of fluid you use to mix your PPI in that day. So don't forget those fluid creeps that will eventually come back to haunt you.
I think that's very important in terms of, we know we're administering 80 mils of fluid per hour, but then we forget that the magnesium sulfate is mixed in normal saline, and we forget that the labetalol also needs to be in an infusion, and all of that correlates to the amount of fluid that the patient is getting. So I think you commented on a question we have. Please, can you comment on the use of furosemide in the no-flow state, especially in the pre-eclamptic patients? And I remember in one of our grand ward rounds, one of the comments was like, if the patient is not peeing, it's like flagging a dead horse. And so I think, looking at fluid challenges, it's also on the other end looking at the Lasix challenges and who it will work with and who it won't. So essentially, if the patient is not peeing and you've tried it once, then the Lasix is not going to work. And the other entities are what you would offer. I think it's important for us to be able to evaluate when we get to the fourth phase and when we are over maintaining, or we've stabilized, but we trapping all of this fluid. So Zainab, I would like for you to just take us through an approach or any principle guide that you would be able to afford to us, because you are often called in when we need, urgently need the airway because our patient is flooded with pulmonary edema, or we forget that even the soft tissue becomes edematous when trying to secure an airway. And then our non-invasive ventilation is null and void in these patients. I would like to give out a message in terms of how we can prevent getting to that stage of where we need to now remove fluid, and what principles you can offer us, especially in that hypertensive and septic patient. Because of the capillary permeability, we know we've got damage-associated molecular patterns on the one hand, we've got pathogen-associated molecular patterns on the other hand, and the DAMPs and the PAMPs are married. So I'd love to hear what your approach should be and how we can assist, especially our junior doctors on site, to prevent this from happening.
So I think the first thing is to recognize that the pathophysiology of a preeclampsia and hypertension in pregnancy and the fluid changes there are quite different to those in the septic patient. So we can tackle the hypertensive patient first, recognizing that both of them have significant endothelial dysfunction that causes capillary leak, and fluid will accumulate in both states, but for different reasons. So your preeclamptic patient comes in as an emergency to you with hypertension that can be life-threatening to the mother, and then also that can cause placental insufficiency over time and cause adverse effects in the fetus as well. So you, as a knee-jerk response, the first thing is to try to get that blood pressure down. And what we generally do is give a short-acting agent together with a fluid preload to ensure that once you have vasodilatation, you don't have a dramatic drop in your preload and a decrease in your blood pressure, which would mean that you now have a decrease in your cardiac output. So that is what, you can correct me if I'm wrong, Shastra, but that is how your general hypertensive patient coming in with preeclampsia would be managed, coming to an obstetric unit. The problem with this patient is if they stay in the obstetric high care or requiring treatment over a period of time, what will happen is exactly what we've discussed now, is that over time, that one fluid bolus will become another one and another one and another one as the blood pressure medications start working, and now the BP may be trending downwards. But recognizing that this patient the whole while has this endothelial dysfunction and fluid will accumulate over time. Very importantly, we also need to recognize the effect of the cardiovascular function in the preeclamptic patient. So not only do they have endothelial dysfunction, but they also have, or may have rather, impaired systolic and quite commonly impaired diastolic function in the heart that we don't really pay attention to, because our immediate management is to stabilize blood pressure, stabilize the mom, and then plan for delivery when it's appropriate. So we need to recognize that in the pathophysiology of PET, you have those patients who have abnormal cardiac function as well, and you have patients who may have more preserved cardiac function, and that plays a very important role in how that parturient will add to what about. Commonly, we do involve cardiologists and other colleagues to assess our patients. And very importantly, one of the markers you can look for in these patients is an elevated left ventricular and diastolic pressure. And where these patients have that, we know that this patient has very little room for fluid overload. They are becoming fluid tolerant and will soon be fluid intolerant, and that's where we're going to have the fluid overload accumulating over time. Then just to come back to what Pavan has said on fluid creep, that is something that we don't often pay attention to in the ICU, in the obstetric high care, but not only obstetric high care, but many units where critically ill patients are. We administering a number of fluids, feeds, maintenance fluids, and so forth. On top of the patient may be taking orally, like most of our obstetric patients will not be intubated. They will be in a unit where they monitored. And all that fluid we need to add up over time. So your cumulative fluid balance, even in a patient who is in your high care, is quite important. And you'll see that fluid creep over time. And we know that fluid creep is very deleterious in terms of outcomes in patients. So that kind of summarizes the PET patient. In contrast, the septic patient is quite different. So that patient has endothelial dysfunction from the DEMS and PEMS that you've spoken about. They have massive vasodilatation, commonly with preserved cardiac function, but over time they may also develop a septic cardiomyopathy and have cardiac dysfunction over time. So we know that there are no specific guidelines for management of obstetric sepsis. So we take a lot of our lessons from the Surviving Sepsis Guideline. And there we know, and it has been endorsed by some obstetric societies as well, that usually a septic shock patient will get isotonic crystalloids of about 1 to 2 liters during the early resuscitation phase. And especially in the septic patient, the Rose model becomes very important to recognize where on this trajectory is your critically ill obstetric patient. Do they need aggressive fluid resuscitation at the beginning? When do you need to start tailoring your resuscitation and looking at dynamic markers of fluid responsiveness? And when those markers are no longer positive, even if your blood pressure is low, you need to consider other causes. Do I need a vasopressor? Do I need an inotrope? Do I have a cardiac cause? Do I have another cause? And then we will avoid that fluid creeping up over time, where we're chasing a blood pressure without looking at the other causes of hypotension in that kind of patient.
Perfect. Thank you, Zainab. I think you so eloquently captured each of the scenarios. And I know that while you were speaking, I got goosebumps because it's things that we are faced with and things we need to remember. So thank you for that. Pavan, this is for you. What is the role of Voluven and other colloids, especially in a patient with hypotension?
So with regards to other colloids and Voluven, the there was a Cochrane review that showed that there was no difference when it comes to post-spinal anesthesia and hypotension, um, where the use of colloids and crystalloids were found to be equivalent. However, we have to look at what's the problems with Voluven or your other colloids. And the problem there is we have the increased risk of excessive AKIs, we have the increased morbidities that are associated with the increased mortality, we have the increased risk of anaphylaxis as well. So those are generally avoided. You would rather go with your balanced crystalloid, and in the interim, while you're getting that blood pressure up, don't be shy to start your pressor early. So that would be the
Yes, I don't use colloids in obstetric high risk practice. Voluven, I remember very, very long time ago, Zainab.
Yeah.
We used to have that available, near the labor ward if there was a PPH, or we'd put that up just to get that preload going to try and maintain a cardiac output. And I think we need to appreciate that when there is an element of shock, the kidneys also take a hit. And if you're going to then add on, like you said, Pavan, another poison, you really need to be aware of, what the pathophysiology is for that patient specifically, because it needs to be an individualized therapy. So I know that in recent practice, we haven't really used those two agents as prominently as we did many years ago. And I think that was more because of the volume expansion. And very similar to the FEAST trial, when we're looking at sepsis with malaria in children, they all were given boluses and they did beautifully well. And in long term, we realized that cardiac output actually wasn't maintained, and these children succumbed and eventually deteriorated. So I think it's the same concept, that we mustn't get a false sense of security to think that we're using something that's going to provide the cardiac output for us. It is us who actually needs to create that system for the patient, and it's a journey. It's not a one-off bus stop that we are putting this down in a concrete prescription, and it doesn't change with time, because as you've shown us, Pavan, that entire journey changes with time when we look at rows. So I think that is important, and I hope that answered your question, anonymous attendee. I have another one which I think is extremely pertinent. There's actually two, but the first one I'm going to look at is electrolytes. And I think when we were basically approaching, what could be common entities when it comes to fluid, is the element of SIADH in pregnancy and hyponatremia already in the preeclamptic patient, who is no longer fluid responsive because they've become intolerant, but there are features of fluid overload. So this question is, can you please comment on the hyponatremia in patients who are receiving oxytocin, and what fluid then should we be giving these patients? And I think this is also relevant because oxytocin needs to also be mixed in a medium for a titration. So Zainab, in terms of your theatre experience, you've got a bled out patient on the table, or a hypertensive crisis, or a HELP syndrome. How do you mitigate once you've looked at this blood gas and waited for results in terms of your fluid stewardship for a patient who's got hyponatremia?
So I think the important thing with hyponatremia, you have to delineate the cause of the hyponatremia. And again, the assessment of blood volume becomes very important here. And you divide the patients into three main groups: those who are hypovolemic, euvolemic, and hypervolemic. So the hypervolemic groups are generally those with AKI, liver failure, or cardiac failure. The euvolemic group are quite commonly the ones with endocrine dysfunction, just to make it simple. So SIADH would fall into that group. And then the hyponatremic group would be those who have losses from GI or from renal losses. Obviously, the patients with hypovolemic hyponatremia will need fluid replacement with a fluid containing sodium. The patients who are hypervolemic, they actually need management of their underlying condition. Where the hyponatremia is causing symptoms, so they're symptomatic from a central nervous system point of view or so forth, then we may need to treat and correct that hyponatremia with concentrated sodium, so 3% sodium or 5% hypertonic saline, to mitigate those central nervous system effects, and then come down to what is actually causing the hyponatremia. So similarly, in the SIADH patient, we need to consider if this patient is hypervolemic or euvolemic, we can't really be giving that patient more fluid. We need to find the cause and then treat that cause. And then we're going to be able to get on top of the hyponatremia in that patient.
Thank you. So I think it's important that if you do identify a patient with hyponatremia in the labor ward, you feel that this patient needs to have an infusion of oxytocin, that you choose the right fluid and go through all the Ds that Pavan has offered to you. Often we talk about hypertonic saline, so the 3%, the 5%, and there's different ways of calculating how much of that you need. And there's a method of how quickly you also need to shift that sodium. So these patients need to be in a facility where they can be monitored adequately, and you don't want to cause any further harm by accelerating that replacement too quickly. And in some cases where they are hyponatremic and they are hypervolemic, you would need then to be in a setting where Pavan has says in that fourth phase, you then need to try and get that fluid off the patient to try and assist them with the electrolyte imbalances. So I'm very much aware that we are in facilities that may not have all the resources we have, either in terms of equipment, skill set, supervision, and administrative support. But I think what is the message that is coming out here is that you need to remain vigilant. You need to be able to recognize where there's a problem. You need to be able to initiate correct therapy from the start, and you need to then monitor yourself in terms of how we are providing this therapy to the patient, which is extremely important. So I think that that message in terms of recognizing there's a problem and also preventing that fluid creep from happening. Sometimes patients can become hyponatremic under your care because the amount of fluid that gets extrapolated from day to day that they are on. We use a lot of oxytocin infusions for postpartum given water intoxication, perhaps better with, I don't know what the last word is. Say
I think
again?
it's carbitocin. I think
Okay,
she's talking about
K-Bell.
carbitocin.
Yes, carbitocin. Have you used carbitocin in your practice?
No, we don't have it available in state practice, but I think commonly in the Johannesburg private hospitals, they are using carbitocin more frequently.
Okay, so yes, thank you very much for that. There are alternatives then when we're starting to talk about these high-risk patients and what we can offer them. For the three of us, and I think Pavan, you can start. I think this is an important entity because this is a question about blood and blood products, and it's especially looking at hemoglobin cutoffs. We've learned about restrictive versus liberal. We've learned about the cardiac patient cutoff at 9. Our TRIST trials, our TRIC trials all tell us that with an HB of 7, we should have adequate oxygen carrying capacity. I think it's very different than the pregnant patient who's lost a massive volume and hemoglobin, blood, and all of her clotting factors, but she's also in the physiological changes through pregnancy, very close after delivery, and she still needs to maintain the well-being of a fetus. So sometimes we also have lactating mothers. And so this question is, what are your thoughts on the use of blood products based on hemoglobin cutoffs, especially in a patient who is hemodynamically stable? We have learned that if the HB is less than 8, you should transfuse, and is this still valid? Pavan, what do you do in your practice?
So from our practice, we have in the general ICU population, it's a very restrictive transfusion protocol, a very restrictive transfusion policy, where in our clinically stable patients, an HB of 7 is our basic transfusion trigger. There are the caveats to that, like you've mentioned with your cardiac patients, also with your TBIs, your traumatic brain injury patients, where those triggers are a little bit higher. However, in the hemodynamically stable patient, we also need to take into account the other factors. Is this a chronic anemia? Is it a acute anemia that we're dealing with? How well is this patient compensating from that? Are they able to cope? We need to look at the type of anemia that this is. So if they have been chilling along at 7.5 and it's have a good in a stable patient, they have an HB of 7.5, and this has been a long-standing problem. Like we've always said in the obstetric patients, in that first trimester, let's give them the IV iron, let's give them the ferrous sulfate, and let's monitor them. If they're stable. If they show you any signs of instability, then your transfusion triggers are patient dependent. Just like fluid management, it should be tailored towards your patient itself and the clinical state of that patient. So as much as our transfusion triggers may say 7, you need to take into consideration all the other factors around your patient, their pre-morbid conditions, their comorbid conditions as well, and anything else that's affecting the pregnancy at the moment.
Perfect. Zainab, happy with that?
Yeah, I think but the question was on hemodynamically stable. In the hemodynamically unstable patient, which we can often encounter in obstetric care, we don't really look for a transfusion trigger. You're going to look at your patient clinically, how much they are bleeding, what's happening with the hemodynamics, what signs of shock there is, and then you would start transfusing empirically rather than waiting for a particular cutoff.
Perfect. So I think that's fair, and I think again it highlights that it's complex. It's not a straight answer, and I think anything in medicine, or as we are learning in 2025, anything in life is not a straight out answer. There's a lot that you need to put in the background. There's a lot of concepts that you need to. What is the context around what is happening for us to make the best decisions? There's a question here. If ICU is not available, how are these patients managed in high care? And number one, we don't want these patients to need ICU. So I think all the elements that Zainab has mentioned are extremely important, especially when patients are coming from the outside and they're referred in. At a district hospital, there are protocols. At a regional hospital, there are protocols. And often these patients will get fluid throughout their stay. Even when the paramedic has approached and on the field, everyone knows we now need to pick up this preload in this pregnant patient, before she gets a vasodilator, etc. So be vigilant of the patient you receive in terms of what they need. Pavan has spoken about non-invasive ventilation, which can be done in a high care setting with level 1 trained sisters that should and watch research. Once you reach those things together, as we've spoken about so the so I think assessment is important.
I think we might have lost Shastra's connection there.
Yeah, I think we've lost Shastra.
Lost Jared. Jared will jump back on.
Was it just me?
Your connection.
Yeah, we've got you back now.
We've got you back, yeah.
Okay, I'm so sorry about that. It didn't highlight anything on my side. So I was just answering the question in terms of the different modalities we can try and use in a high care setting for patients who can't get into the ICU, and hopefully that they really don't need to get there. We have a few minutes, and I think the last question that I had seen was in terms of the same thing I had asked you, Pavan, with the Lasix. And essentially someone wants to know, would the bolus be in terms of an infusion or a bolus for a challenge? I wouldn't suggest we use an infusion here because we're adding to the fluid creep. And also with an infusion, you wait for a longer period of time for a response. So I think generally if you want to try, I would suggest that you actually look at the IVC first to see if your patient is fluid responsive or not. I know often we give 20 milligrams or 40 milligrams and then wait 2 or 3 hours and see if there's any urine output. I must also, I found this very often, that we must flush out the catheter first. Sometimes that's blocked. and that's why there isn't any urine. So sometimes it can be a practical thing that just corrects it. So very quickly, Pavan.
Challenge. The traditional Lasix challenge are bolus doses of Lasix as opposed to the infusions. And those challenges usually use between 1 and 1.5 milligrams per kilo initially. And you monitor that urine output over the first hour. If you don't reach your target in the first hour, you give them a chance up into the second hour, and you see how much of urine you actually produce. And that's generally just a kickstart, as it used to be called, of the kidneys, which it's shown us that, like you mentioned earlier, you're beating a dead horse. If those kidneys have reached a state of hypoperfusion where they're just no longer functioning, you just need to give it time, and no amount of Lasix or pushing Lasix onto that patient is going to help you. With regards to Lasix infusions, we do run them sometimes, especially in patients who are adequately fluid replete, but who just need a bit of help along the way. And these are usually, running at 10 milligrams per hour, 5 milligrams per hour over a 24-hour period, and you're monitoring their urine output. But this also comes with the caveat of you may end up dehydrating these patients even further, because now these are patients that you're sitting in that fourth stage where you have become intravascularly depleted, and a lot of your fluid is sitting in the third space. Now you're pulling out fluid from the intravascular component, and you're having these dips of where you are now becoming fluid depleted while you're still fluid replete. So you're still overloaded, but you're intravascularly dehydrated. In these patients, this is where your IBC assessments come into play a lot of the time. It's where that fine balance of hypoperfusion and overload need to be, that tightrope needs to be walked. You can't be on a Lasix infusion if you are still sitting with a lot of third space fluid. You need to give them more bolus doses where you empty out that tank a little bit, give it time to fill in from the third space, and then empty it out a little bit more, which would be a more rational approach to these patients if you're dealing with things like sepsis and things like patients who have gone through these last 3 phases of your ROSE protocol.
So I think it's important that we're not using the boluses for a challenge. We're actually using the boluses as a therapy. It's the management of removing. So I think that must come across quite clearly in terms of what our intention is. So thank you. Mr. President, I am going to hand over to you in 30 seconds because I see our time is up. I just want to thank Zainab and Pavan so much for their time today. And in closing, I want to illustrate to everybody that this is actually a very vast topic. It's not very easy for us to pinpoint on, common practice because it's such an individualized care with so many entities. So I hope that our journey through getting it just right, not too hot and not too cold, has evoked more interest in terms of learning more about this topic. And I think as a team, we just wanted to say if there was one view, Pavan, that you need to know on POCUS, what would that be?
Let's look at your IBC.
Yeah.
I would say look at your IBC because it's the start of so much. If we look at the amount of traction that Vexus is getting at the moment, your Vexus starts with your IBC. So that's going to tell you about what's going on, not just downstream, but also upstream, sitting in the right side of your heart. So if there's one view you should learn, it's learn the IBC, learn how to look at its compressibility, and learn to look at at the indices that are involved with it.
So I'm going to take that as an opportunity for everybody to please reach out to Pavan and Zainab, and they can illustrate to you hands-on on patients in terms of how to do that. And if anyone needs help, I can cross around the sea and help you virtually. So thank you so much to SOOMSA for this opportunity. And I hand over to you, Jared. It's really been great to be part of this panel.
Thanks, Shastra, and thanks, Pavan and Zainab, both of you. That was an excellent talk and excellent session. I must say, when there was a question about hyponatremia, I'm glad Zainab was answering it because I get palpitations trying to remember that algorithm of hypovolemic, hypervolemic, hyponatremia. I think it gives every nephrologist the sweats as well, which will worsen your hyponatremia. But I was going to say thank you to everyone for joining this webinar and all the previous webinars this year. We've seen such amazing growth within SOOMSA, and it's wonderful to see the number of people that join these and just showing the thirst for knowledge when it comes to medical problems in pregnancy. And also just amazing to see the multidisciplinary nature of these talks, having obstetricians, critical care specialists, anaesthetists, physicians. We've had midwives, physiotherapists, all sorts joining these talks, and we really appreciate that. I encourage you to please head over to soomsa.co.za and join the society. These talks are open to everyone, but membership helps. It's a nominal membership fee, 300 Rand for the year, very little. You can't even put in much petrol for that these days. So please consider joining SOOMSA to support these webinars and the work that we do. And on that note, I think we will close off our educational endeavors for 2025. So wishing everyone a wonderful end of the year. I know it's about 7 weeks to go, but it's December already in my mind. So have a wonderful end of the year, and we'll definitely see you in 2026. We've got some wonderful talks planned already, doing some stuff with the Psychiatry Society, leading up to the International Marseille meeting, a couple of things on postpartum hemorrhage, and looking at different new novel therapies and that sort of thing in postpartum hemorrhage. And then lots coming in the iron deficiency world and the radiology world as well. So thanks everyone, and thank you again to the panel and Shastra for organizing tonight's meeting. Really appreciate it. Have an excellent evening.
Thank you. Good night, everybody.
Thank you.
Everyone.
Night, everyone.